Thank you so much for joining us. My name's Julie McCrossan and I want to welcome you to this Wolper Wellbeing program webinar hosted by Wolper Jewish Hospital, of course, and Friends of Wolper. Our topic tonight, as people come in, is cognitive impairment and dementia. We're going to look at understanding the disease and also support, of course, for people with a diagnosis and carers. Our fundamental purpose is to share some of the latest information from genuine experts and also to give you the opportunity to ask questions and make comments. Our format tonight will be predominantly a group interview process, but we will also have a presentation. And the most important thing is that we will regularly go to questions. And from right now, if you see the Q&A button down there on the right, you can click that and you can start asking questions or making brief comments right now. So please use the Q&A all evening to ask questions, but please do not use the chat. And we have Dr. Alan Schell, a general practitioner and an enormous friend of Wolper, who'll be monitoring your questions and comments all evening, and I will come regularly to him to get questions, and we'll do our living best to answer as many questions as possible, possibly not all, but we'll come as close to it as we can. So it's my pleasure now to ask Dr. Alan Schell, my favourite general practitioner in the universe, to kick off. Please welcome him with clapping, which is deaf sign clapping. This is how we give each other warmth. Thanks, Alan.
Thanks very much, Julie. As always, we appreciate you being here. And so far we have over 200 participants and we expect certainly many more. What we're obviously trying to do here is provide you with as much information as we can from our panel of experts. And Wolper has been running the Wellbeing evenings for many years now, perhaps over about 18 years. And for those new to the system here, we have Q&A, we have time for questions, and we have expert panel to at least answer those as best we can. We have your email and we'd like to keep in touch. So next year we'll have another series of talks, approximately every couple of months, and we hope that you can join us for those. Before we start, we just want to say that we are supporting also Dementia Australia, and we have a very fine young lady as the Regional Director of New South Wales and ACT for Dementia Australia, Holly Miller. And we'll just hand over to Miss Miller to give us a bit of a rundown of what Dementia Australia is and what it does for you and me.
Thanks, Alan. So I will start a short presentation just to give everybody a bit of a rundown of what it is we do and the services that we provide as an organisation. So I just want to double check that everybody can see the PowerPoint presentation there correctly? Great. I'm getting some thumbs up there. So I want to start by, I guess, extending a warm welcome to everybody. Presentation is stuck. Not ideal. I'm thanking everybody for joining us today and making the time and effort to attend the presentation. Now, I do want to, I guess, give you a bit of a rundown of what we do. So we represent about 500,000 Australians. And I guess a lot of what we're trying to do at the moment is clear up myths about dementia and support those people living with dementia in the community to live as rich and meaningful life after a diagnosis as possible. So some of the, I guess, myths that are out there are that people living with dementia, don't live alone, that they don't live within the community, that they don't live in rural areas. And so I guess I want to start today's presentation by, I guess, busting those myths and acknowledging that there are plenty of people living within our community today who are, not living within residential aged care. And I think that is a huge myth that, we all want to bust. So some of the strategies that we are trying to take are to reduce the time that it takes to get a diagnosis. And as you can see here, it takes a person over 65 on average 3 years and a person under 65 on average 7. So to help support those people in the community who are asking questions or concerned about dementia or want to know any information or are a family or friend or carer of someone living with dementia, we have a free national helpline. As you can see here, it's open 8 till 8. And that is a nationally free available service. We also have a web chat there. And I guess that's available for any question you have. I think a lot of people hear the word helpline and think, I don't need urgent help, so I won't bother calling. And I guess what I want to reiterate today is if anybody has any type of question, could be around how to get a diagnosis or what the signs and symptoms are. It can be something very basic, or it can be something around needing some emotional support. So I guess during COVID, we have noticed that we've been getting more calls around people needing emotional support and guidance. And people do want to connect with our services and programs. And we can discuss other support services that they may be able to seek. So we're there to support them and refer them and assist them in any way we possibly can. And as I say, you know, the callers, they're very warm and friendly, and they'll explore what your specific circumstances are and try best to support you and link you with the right information and services from there. So some of the kinds of things we provide, because I think there is a lot of myths around us being a charity and that we must just raise money for research in dementia, and a lot of what we do is actually provide post-diagnostic support. So we currently have a program where you can get one-to-one support over a 12-month period, and that's around 6 sessions, and that could be done in a way that suits you, you know, and that's to help you in that time and that initial diagnosis period. We also have programs, and I guess myself being an engineer by background, I was quite cynical about the effect and impact of a group program. But having attended these, I can honestly, you know, speak from my own personal experience of attending them, the huge and significant impact that they have on the lives of the people that attend. And both carers and people living with dementia attend those programs. And I guess not only does it provide you with the information and support and strategies for the journey ahead, but it also provides other, you know, like-minded people who are in a very similar situation, and enables you to plan and think ahead and think about the changes. And I can't speak highly enough of this program. And as I say, as someone who was cynical myself, and I'm very honest in admitting that, it is a fantastic program, and you can ring the helpline and get, you know, information, or go on our website and find all of the information about these. So as I say, we have family care education, and during COVID, that's all been made available via Zoom. So if you're enjoying this platform, then you can access those programs. And as I say, they're on our events section, and they're all free. You know, and I guess there are a lot of different topics that might be covered in there that are relevant to anybody here today. And whether it's just basic information you're looking for, or more complicated topics that are more relevant to you. We also have wellness programs, and I guess we're very keen to care for the carer. You know, that is a big topic for us, and we appreciate that carers are doing it tough, particularly at this time in some instances, being more isolated than ever during COVID, and with routines changing. It's been a challenging year for everybody, I'm sure, and nobody has escaped that. I'm quite willing to put myself on the line and say that. So you can also get free counselling, and I think everybody thinks you need a Medicare referral for that. That is not the case. You can get 10 free sessions from us, and they can be delivered to you in any way that suits you. I'm sorry if I'm rushing through this, but I was told to keep it short and sweet, and I'm trying to give you as much information as I can in the time frames I've got. But as you can see from everything I'm saying, there's a lot of it available, and there's a lot that's free. We do have professional education if you are in the sector and looking for professional education, and I guess this potentially might not be the right forum to promote this, but it is something that I do want to let people know about, and that's in nationally accredited education, and in a variety of different ways. So if you are challenged or to keep track of everything I've said with my strong accent and speed presentation, then you can go on our website, you can contact me, and you can also contact the Wolper Jewish Hospital, who will be happy to give you our information. But I hope that, you know, you've learned from this presentation that ultimately, you know, there are a lot available from Dementia Australia, a lot of services and support, and we are here to help you in any way we possibly can.
Thank you very much. Thanks very much. And as Holly has said, that we will have that information available to you, return email in the next week. So thank you very much. Over to you, Julie.
Thanks, Ellen. And I just wish we had time to find out from Holly how she moved from engineering in the north of England to working in dementia support here in Australia. But that was a marvellous presentation. Ladies and gentlemen, welcome if you've just joined us. My name's Julie McCrossan and it's my pleasure to be your MC this evening. I'll just do some basic housekeeping again, as we've had quite a few join us, and we'll kick off our panel discussion. So the first thing to say is that this evening, Jewish Care Victoria is a partner with us for Victorian viewers, and we do welcome people from Victoria who've joined us tonight. At approximately 9 p.m, just a little bit before, we'll invite Victorian viewers to stay on with us, and of course everyone in New South Wales and other parts of the world who've joined us are welcome to stay on, but we will have a particular focus on support services in Victoria towards the very end of our presentation. And a reminder that you can start putting questions or brief comments in right now. You'll see the QA function. Just click on that, write in your question. You can have anonymous questions. They're absolutely welcome. Do not use the chat. Only use the Q&A for asking questions. Dr. Alan Schell, who we just met, will be monitoring them, and I will, on regular occasions, go to him and he will give us an overview of what's coming in and plus share pertinent questions, and we'll get through as many as we can. Now, Jackson is in cyberspace. I think he is actually in Melbourne, controlling everything. Jackson, are we able to bring up a poll? If yes, could a poll appear on the screen? Ladies and gentlemen, would you please answer that poll? And it should disappear, I think, once you've answered it. I'll just be quiet while you quickly indicate your age range. And Jackson, do we have a second poll, or is it just one this evening?
Just the one this evening.
Thank you very much. Well, we might take the poll off the screen. And thank you very much. And we'll move to our panel discussion. So our primary focus tonight, of course, is cognitive impairment and dementia, understanding the illness and how to prevent it, and support for patients and carers. And we have 4 panel members. I'll introduce them more fully as they come on for discussion, but we have Professor Henry Badati, AO, a researcher and old age psychiatrist, Associate Professor Steve McFarlane, another old age psychiatrist working for Hammond Care. We welcome also Professor Lynn Chenoweth, a Professor of Nursing at the Centre for Healthy Brain Ageing, and of course, Dr. Alan Schell, who, as well as being question monitor, is going to give us a general practitioner point of view. What I'd like to do is come first to Professor Henry Badati. So let me tell you just a little more about him. Henry is Professor of Ageing and Mental Health at the University of New South Wales, co-director of the Centre for Healthy Brain Ageing. He's the Montefiore Chair in Healthy Brain Ageing, and in his role as researcher, it includes being director of the Dementia Centre for Research Collaboration. Even if we can't see you, this is deaf sign language for clapping, and I urge you to do it because there is some evidence in the land of cyberspace that people do feel the need for warmth and connection. Could I welcome Professor Henry Badati to the screen and ask you, Henry, just to give us some definitions, for example, what is cognitive impairment?
Well, cognitive impairment, cognition is our thinking functions, memory, language, understanding, being able to find your way around Westfield car park. These are all our cognitive functions. And impairment is just that, where they're not working as well. So we all have periods of cognitive impairment. We've got the flu, we're not cognitively as able as before, or we've had too much wine to drink at dinner. That can also cause cognitive impairment. But what we're talking about is cognitive impairment, which is not just transient, but it's present consistently and usually progressive in the conditions we're talking about. And it often affects those multiple different domains, we call it. Most commonly short-term memory. Who hasn't had the issue of seeing someone, you know who they are, but you just can't remember their name until 5 minutes after they've gone. So we all get some cognitive impairment from time to time, but where it's progressive, where it's starting to interfere with day-to-day life, that's when we start getting worried.
Could you give us an overview of the range of conditions that can cause a level of cognitive impairment that's affecting daily life that can be concerning, and also give us a sense of the different types of dementia, because as I understand it, there are a range of types. Just so we have an overview of the territory, as it were, please.
You're absolutely right, Julie. There are over 100 different types of dementia. So we can have what's called mild cognitive impairment, where people have noticed some problems with their memory or other thinking functions, but are able to function normally day to day. Then we can have dementia, where we get decline in cognition, is now impaired, in at least one of those areas. It might be what we call executive function, which is planning or organization or understanding, or it could be in language, finding words for things, or it could be in multiple domains like that. But it does interfere with function. So people are not able to function day to day as they used to. We can also get cognitive impairment when we're very sick, when we get the flu, perhaps, or after an operation, after an anesthetic. And this is sometimes called delirium. It's an acute confusional state. This often recovers and people come back to normal. But in people who've already got some cognitive impairment, they're more vulnerable to delirium. So people with dementia, when they go into hospital to have their hip repaired, they're very, very prone to develop delirium on top of it. We can also get cognitive impairment which is static. For example, after a head injury or after a stroke, and people may have some impairment, and it may actually get better over time. We know that the problems after a stroke are worse in the first month or two, and for many people, there's some gradual recovery over the next few months, unless they have more strokes. So there are a variety of conditions that can cause cognitive impairment. Now, coming to dementia, there are many types, as we've discussed. The most common type is Alzheimer's. People often ask me, what's the difference? What's the difference between Alzheimer's and dementia? And I say Alzheimer's is just a type of dementia. Dementia is the umbrella term, which means cognitive decline interfering with day-to-day function. Alzheimer's disease is a neurodegenerative condition. What that means is the nerve cells are dying inside the brain. We know a lot about what's happening, and we can talk about that later if you like. But there are many ways the nerve cells can be affected. And in Alzheimer's disease, there's this buildup of an abnormal protein called the amyloid or A-beta protein. But in other dementias, like frontotemporal dementia, there's a buildup of another protein that can be toxic, the tau protein or the TDP43. It doesn't matter for our purposes tonight, but these are sometimes called proteinopathies. And so something goes wrong with some of these crucial proteins in the brain. They get distorted and they clump together and they cause damage. The second most common cause of dementia is vascular dementia, with problems with circulation in the brain. It could be one strategic stroke or multiple small strokes, or just thickening of the very small blood vessels, not the arteries, but the arterioles, the tiny tributaries. And when they thicken up, it doesn't allow the nutrients to get to the brain. Now, we're very familiar with coronary artery disease. We're not so familiar with cerebral artery disease, but it's the same principle and the same risk factors as well. And the final one I want to talk about is Lewy body dementia, which is quite a common cause of dementia, but not well recognized.
And just before I come to Alan to get a general practitioner's point of view, there's great fear in the community of dementia. And I just want to ask this simple question. Is it possible to have a diagnosis and live well, either at home or with support in some form of residential service, for quite an extended period of time? Is it possible to live well with a diagnosis? Absolutely,
Julie. I'm so glad you mentioned this. And there's been this nihilistic attitude, nothing can be done, it's all over. When a person gets a diagnosis of dementia, that's the end of life. And many people live a very full life, a loving life, a life with joy for many years with dementia before it goes to the end stages. And that's certainly part of the aim of what we're trying to do in much of our work as well. So positive living with dementia. If we think about stroke, after a person has a stroke, they get rehab. After they get a diagnosis of dementia, zilch. But we're working on reablement, building on the assets the person has, compensating for the deficits, living well with dementia.
Thank you so much. And I've done some work with Dementia Australia this year, and they have a number of people with a diagnosis who are advocates who come on. I interviewed people with dementia. So I just think it's really important for people to realise it's, otherwise people are at risk of hurting themselves, aren't they, of self-harm if they don't think there's hope. But let me come to Alan. I want to ask him a few things as a GP, and then he can get into his role as question monitor, because I can see questions coming in. And you remember Dr. Alan Schell is a general practitioner and is also involved as a visiting fellow at the Dementia Centre for Research Collaboration at the University of New South Wales, as indeed Henry is the director of. Alan, as I understand it, you want to really get the message out that a timely diagnosis is absolutely critical. So why is it critical, and what are the sort of things that you might notice happening that means you should talk to your GP about what's happening to you cognitively?
Well, I've been working with Henry for now well over 10 years, and part of that was doing research into general practice in particular. And one of the first projects we did was why GPs don't diagnose dementia. And I think some of the things that Henry mentioned, one in particular is the nihilism, the negativity, because I don't have a drug to give you if I make the diagnosis. And on top of that, there's that fear on the patient side that I don't want the doctor to know that maybe I've got a memory problem or something's changed. So we have those issues before the person walks in the door. Either the doctor has some barriers to making a diagnosis and the patient or their family, in fact. And I think if you're asking the question, what are some of the things you could do, there's some recent studies that people who self-decide that they've got a problem are often told, oh, that's age, or you're getting older. So, and as Henry said, I've forgotten something. I can't remember who Bob was, and now I remember who he is. So we have all those issues going on today, but unfortunately, people have become more concerned about having dementia. So we have the worried well. And on the other side, there are people who say, look, I've got some problems, and they come along to their GP. So the GP has in Australia, about 80% is considered a Medicare card holders will see a GP at least once a year. And as we get older, we often see them more often. And I guess it's up to the staff, they see it at the front desk to see, well, Mrs. Smith looks a bit different, or they've missed their appointment and they turn up early or late. Those little things happen. Or the person comes along with their daughter or their husband and say, look, we're a bit concerned that mum or my wife is having some difficulties. And that could be with their activities of daily living. But on the other hand, we do have to be good diagnosticians. And in the Medicare system, there is an over 75 program where doctors can assess that person. We can have an OT assessment. We can have a number of other allied health members, the team, assess people. And for the GP, it's also important to look at what drugs they're on to see if their blood pressure is being well managed, their type 2 diabetes. They're all issues that we all have now in the community, as my 40 years of medicine have made or assisted in people living at least 10 years longer. So age is a risk, but not everybody's going to get dementia out there. So while I may have confused the answer, okay, there are a number of things that happen as you come in the door on the doctor side, but doctors happily are changing. We've got a very strong program, as Holly mentioned there, Dementia Australia has, ones that I've been doing in a timely diagnosis around Australia. And we want people to ask that question, look, I've got some problems, but they may be, in fact, in occasions, something to do with your thyroid. You can get a pseudo dementia due to somebody's inactive or low activity thyroid. So doing the normal assessment at 75 plus or even 65 plus, looking at their pharmacy, their medicines, looking at their biochemistry, because again, people get dehydrated, don't eat well, so nutrition is important. And one of the big important medications you can give a person is a prescription for a change of lifestyle. So no smoking, doing more exercise, watching what you eat, and being active. And as Henry says, even with the diagnosis, looking at all those factors, because they will improve your longevity despite the fact that you've had a diagnosis of dementia.
Look, Alan, I want to get you to be a question monitor, but I'm just going to ask you one more question. I'll then ask Lynn Chenoweth a question, and then I would love to get our first questions from the audience. But my question is this. I can't be the only person watching tonight who's had a GP pull out a sort of a sheet of paper and get me to answer a series of questions. And my understanding is they were checking if I had anxiety or depression. It was like a standard test. With my late mother, I have been present with her over the years while a number of people have done tests with her to assess her cognitive impairment. And my mother was always aware that that was the purpose of it. And the score was shared with her. And when there was some decline from vascular dementia, she was part of that conversation with a very caring geriatrician. And as I guess the question is this, is part of what we need to do is in a way bring cognitive impairment out of the closet, as we have with anxiety and depression, so that a patient may actually say to a GP, look, do you think we should check how I'm going upstairs?
Yeah, so that's been some good research in if people, perhaps, in fact, in the UK some years ago, they wanted to see if they could find all the people that have dementia. So everybody got tested. So the tests we have are, in fact, assessment tests. They're not a true test because you have the MMSE, which is probably the ZMOCA, the Montreal assessment. There's GP Cog, which Henry Burdatti and others have created to look at the assessment of that person's cognition, how well they're doing compared to the test standard. So we do have some tests, but if somebody is concerned about their memory, is concerned about their change in activities, then that's a prompt to do a biochemical review, to do an ECG, to do some standard things, and to do some of the assessment tests, whichever the GP or the team like. Typically it's MMSE, and there's a clock drawing test. And those things can help us, as they had with your mother. Look, this person is moved away from what we'd accept as a normal range and moving into the range that's suggesting cognitive impairment. So I think that people, yes, they in the last century feared cancer, and often people didn't turn up in case it was cancer. Now we're a bit more cognizant of cancer, breast cancer. We reduce that because people are more aware they should be testing. And I guess as people are getting older, they are fearful of having more tests. If they come up with a diagnosis, now what do I do? Is the question. One, they get embarrassed. Two, they think they've let the team down. In some cultures, it's a religious thing. Oh, you've been a bad person. Look what's happened to you. So we have a whole mixture of reasons why people don't present, but we shouldn't deny them doing assessment tests and thorough investigation of standards. So we do have a baseline at least, because if things change, we can say, hey, 12 months ago, this is how you had it. Now, look, we've got a problem. Let's talk about it and see, as with Dementia Australia and with Dementia Services, with Jewish Care, with Victorian Jewish Care, we have people who can help you live a more fulfilling life despite the diagnosis.
Thank you so much, Alan, and I'll just keep practicing spelling world backwards and counting down from 100 by sevens. I'd like to welcome now, if I may, and I'll come back for questions in a moment, so thank you. Please keep putting your questions in. But Professor Lynn Chenoweth is a Professor of Nursing at the Centre for Healthy Brain Ageing at the University of New South Wales. And again, Lynn, I guess I was wanting to begin. I know you're doing a lot of work in supporting carers, and I'd like to talk to you more about that later, but what's the message of hope for carers who tuned in tonight because perhaps their husband or their wife or someone very dear to them has had a diagnosis of one kind of dementia or another, and they're saying, is there hope in our future together? What's your basic message?
Yes, Julie, well look, the main thing that we have to remember is that all human beings are human beings. And so just because a person is getting some sort of cognitive decline, they're losing capacity to make decisions or to actually navigate their lives in the way that they did previously, and this is probably going to continue, we have to remember that the human relationships that we've developed are the things that sustain us all. And so keeping that relationship going, being understanding and perhaps a little bit more patient, explaining things and giving people opportunities to self-care, to make decisions for themselves and to be part of the decision-making processes. This is the main thing. And once families realise that the person can be fully involved in all of the decisions as changes occur, and that they can be fully involved in family life in ways that they're capable of being participating in, then the whole family feels more relaxed. The whole family stays connected, and the family feels that there's a sense of a future, because a person with dementia has a future. Their future is day to day, and it's even into the future, planning a holiday together, planning where we're going to go to dinner on Saturday night. So the whole thing is about maintaining human relationships. And once we do that, then everything we have to face, we can face together. So that's the key message.
And thank you for that. And Lynn, is another key message too, that many people with dementia are still themselves.
Yes.
I think there's a feeling abroad for people who are not familiar with cognitive impairment and the different dementias that someone loses themselves altogether, whereas I'm old enough now to have met people with all sorts of life experiences with dementia, including a lady who made it to nearly 101. And yes, she had become there'd been very significant changes, but she was fundamentally herself to the very last day of her life. I mean, that is possible, isn't it?
Yes, well, look, the thing is that generally speaking, who we are develops early in life, and that personality gets shaped and changed with the experiences that we go through, and with, of course, the relationships that we develop as well. But the fundamental person that we become as an adult is still fundamentally there. And the thing is that the person may not be able to express how they feel sometimes, or they may not be able to express feelings in a way that we understand, but their deep understanding of who they are exists. And it is our job to try and get into that and to understand and to enable the person to be who they wish to be and who they really are. That's one of the issues we find when people go into some sort of healthcare situation, that there is an assumption that the person who was there is no longer there, and people are treated in the same way. Everybody's treated the same way, and that doesn't work well, because every person is quite unique, and every person needs to be able to express the uniqueness in a whole range of ways.
Well, I will come back to you, Lynn, and I'll also come to Associate Professor Steve McFarlane later, but let's have a period of questions. I come to Alan Shell now as question monitor. Can you share with us the sort of themes that are coming in, and also give us a couple of questions, please, Alan?
Look, a very strong one is, and that's one question that's being often asked, is questions around the genetics. In other words, one of our attendees has written, I know there are different stages, but I've had family members, 2 in their 70s and 1 in their mid-80s, having the onset of dementia. Does that mean I'm going to get it? And are there any dementia genetic tests? And if so, do I believe them, or how high is the risk if it's positive?
Look, I might come to Associate Professor Steve McFarlane, Head of Clinical Services at the Dementia Centre for Hammond Care, and get your response, sir, and I might get one from Henry as well. What would you say, Steve?
Sure. Look, I get a lot of people come to see me in private practice really worried because they walk through the door and they say, all 4 of my grandparents died of dementia. I'm really worried that I'm going to get it. The first question that I ask in return is, how old were your grandparents when they were diagnosed with dementia? And if all 4 of the grandparents got it in their 90s, that's probably just bad luck, because the single biggest risk factor for developing dementia is simply advancing age. So although family history is important, and it's something that we'll focus on when we're taking a history of somebody with cognitive impairment, really the age at which a close relative first developed cognitive impairment is really important, because most people who get it at quite advanced ages in their 80s and 90s, there's no genetic basis at all. That's not to say that there aren't forms of dementia that are genetically determined. They're actually pretty rare, but when they do occur, they tend to affect people really at quite young ages. And by young, I'm talking, sometimes as young as in their 30s, but certainly in their 40s and 50s. And there's specific genes associated with those types of dementia. There are other genes that increase our risk for having dementia. There's a gene called ApoE4, which if you have that in 2 copies of it, can increase your risk of dementia 12-fold, but it's still no guarantee that you'll actually develop dementia. It simply increases your risk of developing dementia. The other question about genetic testing is if you've got a person in their 40s or 50s coming to you for a genetic test, getting some genetic counselling about the implications of the result is really important, because people at that age have often had their own families, they've had their own children. And if they are carrying a problematic gene, that becomes an issue not only for them, but for the generation below them and for subsequent generations. So it's not just as simple as ordering a genetic test. In the majority of cases of sporadic dementia, they're going to come back negative anyway. It's probably worth doing in many cases of young onset dementia, particularly if there is a known family history of other cases of younger onset dementia. But in many cases, Julie, it can be a can of worms to interpret, and often more trouble than it's worth.
Yes, I was thinking Pandora's box, but the imagery stays the same. Henry, would you add anything to that in relation to that question? You just need to turn your mic on, Henry. That's a little cognitive moment. Don't worry about it. It's just transitory.
Thanks, Julie. That's right. Yes. So in answer to the question that was asked, the person was worried about his risk or her risk of getting dementia. It is increased if you have a parent with dementia. It depends what sort of dementia too. If it's Alzheimer's disease, which I expect that what he's talking or she's talking about, then it's probably double that for the rest of the population. But it's need to put that in proportion. So people risk getting dementia, say between 60 and 70, is about 1 or 2%. So doubling that risk is not a really great danger. Between 70 and 80, it's probably between 5 and 10%. Over 80, it's about 20%. And so the risk does go up every 5 years. It doubles every 5 years. So yes, there is an increased risk, but it's important to remember that 40% of the risk of dementia can be attributed to environmental factors that we can all do something about. And tuning into Wolper seminars, webinars are a pretty good thing, but any cognitive stimulation is good, but particularly education in younger life may be even better. Yeah.
Just while you've mentioned prevention, let's just quickly get that message out. The key current recommendations. I heard you on the health report on ABC Radio National with Norman Swan, and I was thinking, can you give us the basic advice, but are there any newer developments we need to know, changes in thinking?
Yep. I have the feeling, Julie, you know the answers when you ask me these questions, because you're always so spot on. Yes, and the basics, as we all know, are exercise for the brain, exercise for the body, exercise socially, so being socially connected, eating well, that means the Mediterranean type diet, plant-based, treatment for your blood pressure, don't smoke, treatment for cholesterol, try and avoid obesity. So they're the things we've known about for some time.
Is there something new?
Yes, hearing. So that probably, the risk has been thought to be almost double in people with hearing loss. The good news with studies that have come out in the last few years is that wearing hearing aids can mitigate that increased risk. So yes, we should all do that. Yeah, but mechanism is not clear to me. The other thing is lack of social isolation, and whether there's a link between hearing loss and social isolation. We know there's that link, but whether that's the link to getting cognitive impairment or there is some other link. The other things that have come out is air pollution. That's a new one. The risk is very small, but it may be 1 or 2% in the population. Yeah, I think I'll stop there.
Okay, thank you, Henry. Look, what I might do is come to another question, because I've got such a big audience this evening, and thank you for joining us. Alan Schell, another question, please.
Well, as always, the one is, can we treat it with medicines? And of course, there are a number of what they call psychotropic or neuroaffected drugs that actually can make things worse. And on top of that, some of the drugs that you may be taking in your usual day for your diabetic management and for your blood pressure, and then you go along to the complementary medicine shelf and take some other tablets that you think are going to help you, can actually tip the bucket and cause some problems. And the other one that comes to mind is that we talk about protein pump inhibitors. People have these, acid as they get older. We get a bit of reflux because of hiatus hernia, and/or we're on some statins, some drugs to lower our cholesterol. So the issue there for my good professors here is, besides pharmacy review, what's the impact of the protein pump inhibitors to reduce stomach acid, and the fact that there was a paper that said that some of the statins can in fact cause you fogging or cognitive impairment. I think that's been a couple of questions here as well.
Thank you so much. So the question is medications to help or not help. And what I'd like to do, if I may, is to go to both Steve McFarlane and Professor Henry Badati. I might come to you first, Associate Professor Steve McFarlane. What are the key messages around whether there are medications that can help and anything else that you think is important to share on this question?
Okay, well, certainly there are medications that can help and there are medications that can harm. One of the things we do when we're conducting an assessment of people with cognitive impairment is to have a look at the medications that they're prescribed and to see whether any of those medications might actually be contributing to cognitive impairment. There's a whole class of medications called anticholinergics that are often prescribed to treat side effects of other drugs or to treat bladder problems. And then there's a whole range of commonly prescribed drugs that have anticholinergic side effects, which might not be great on their own, but these are very, very commonly prescribed drugs. And when they're layered upon each other, you can reach a certain threshold. So a medication review to cease or review or change to a less potentially cognitively harmful drug is always worthwhile. There are scares from time to time and a lot of misinformation in the lay media about certain drugs and their role potentially in increasing risk for dementia. Protein pump inhibitors is one of the more recent ones, and I think the jury is still out.
Just because for people who don't know what that expression means.
Okay. Hydrogen is a protein. It's a positively charged ion, and hydrogen is a component of hydrochloric acid, which is our stomach acid. So people who have excess acid in their stomach, they're producing excess hydrogen chloride. A protein pump inhibitor will stop that production of the hydrogen ion and decrease acid levels in the stomach. So it's helpful for the treatment of ulcers and for reflux and so on. The mechanism behind protein pump inhibitors is not known, at least to me. Henry might know it. There's a difference to be highlighted, though, between a drug causing dementia or raising the risk of dementia and a drug having cognitive side effects. And this is the distinction that's important in thinking about the statin medications that were mentioned. Statins are cholesterol-lowering drugs, and certainly cognitive impairment can be a side effect of those drugs. So a small proportion of people who are prescribed cholesterol-lowering drugs will notice confusion as a potential side effect, but that's quite distinct from dementia. In fact, there's data to suggest, because elevated cholesterol is such a major risk factor for dementia, that if everybody in the community was actually prescribed a statin and the community levels of cholesterol were lowered across the board, which actually prevent more cases of dementia than if people weren't on statins, irrespective of your baseline cholesterol level. So there's a whole argument about medications aggravating cognitive impairment, medications causing dementia, and anticholinergics have been linked to that, and medications that can cause confusion as a side effect. They're all one thing. A whole nother class of drugs is the cognitive enhancers, drugs that are prescribed to actually improve memory and thinking. And we know that they can have a temporary benefit, either in slowing down decline, in leading to a period of stability, or in fact, in some people, improving memory and thinking for a while before the disease process takes over as well. Those drugs are called cholinesterase inhibitors. In addition to that, Julie, it's become a World Health Organization global priority by 2025 to have a disease-modifying drug available for Alzheimer's. So that goal is still somewhat elusive, but it was approached very closely as recently as last month, when the Federal Drug Administration in the States heard a case about a particular drug called aducanumab that was showing promise in trials. So I think that going forward, we will have drugs that can further slow down or hopefully arrest the progress of the drug, but that's still probably a few years off. The drugs that will do that are possibly in clinical trials now.
Steve, I'm going to come back to you for some thoughts on the recent Royal Commission, but if I could just come to Henry Bedati for a moment. Henry, I guess as I listen to Steve McFarlane, as an ageing person myself, I think to myself, how many Steve McFarlanes and how many Henry Bedatis are out there for my GP to refer me to if I want someone with the understanding, the experience and the sophistication to assess what's happening to me and help me? Because medicine is a series of judgment calls, isn't it? Trying to do the best thing and tinkering to get it right. So do we have enough staff for the ageing population, good physicians who are able to do the sort of assessment Steve's referring to?
Well, the specialists who look after this are old age psychiatrists like Steve and myself, sometimes called psychogeriatricians, geriatricians, and there are many more geriatricians than psychogeriatricians, and neurologists do a lot of this as well. It depends where you live. If you live in the eastern suburbs of Sydney, no problem. If you live in, I don't know, Dubbo, you might have a problem. And so there's a maldistribution. And so the other point is that it's not increased. The aging population is growing. We are now just about, we're over 15%. We're about, I think we're close to 16% over 65. And that's going to reach, you know, in the low 20s and even 25% later this century. And within the age population, the old are the fastest growing, the people over 80 or people over 90. In fact, the fastest growing sector of our population is centenarians. We have, I don't know, I've seen figures 4,000, 6,000 centenarians in Australia, and that's going to be about 40,000 by the middle of the century. So yes, wow, it won't be me. I'm not going to last that long. And but,
you don't know, it's not in your hands, sir.
But a girl born today has about a 40% chance of reaching 100. So that's just an amazing statistic. So no, there are not enough people who specialize in this area, and that shortfall is going to become worse with this aging of the population. Look, and it's worse, as I said, geographically, depending which postcode you live in.
Look, thank you. Look, just before I go to Alan for another question, I want to bring Professor Lynn Chenoweth back in, our Professor of Nursing, Centre for Healthy Brain Ageing. Lynn, again, I want to very much keep in mind the importance of the family and the carers who are just so essential for everything, whatever life throws at us. And you have an interest in a carer coaching program. Would you be able to explain what that is and tell us how it can assist someone who's had a diagnosis and who's trying to live well?
Yes, well, it was mentioned earlier on that Dementia Australia runs fantastic support for people living with dementia and their families, and they offer coaching and training and support. But the program that we ran offered quite a few different strategies, and so the main focus was to actually educate and support families to develop self-efficacy for the caring role, because unless people feel confident, they're armed with the knowledge, they're armed with skills in how to manage people when they become a bit troubled or anxious, unless they have the support of their peers and the support of their family, often education that they might participate in is just education. It doesn't go anywhere. It doesn't get translated into day-to-day living. So what we did was to actually coach the families through a trainer-trainer program. And so therefore we trained up nurses and social workers who were providing support to people living with dementia and their families in the community. And we went all across Sydney, and we went through a lot of the organisations that provide this. So we trained up these staff. And what we asked them to do was to actually help the person to actually develop this self-efficacy, to actually develop the skills through knowledge, and actually to think about looking after themselves. So working out strategies where they could care for themselves as well as care for the person that they were, living with dementia. And they had to learn a number of particular strategies. For example, if someone was constantly urinating on the floor, we actually taught them skills of how to, first of all, de-stress, then to approach the situation calmly, and then to teach the person how to use the right place to go to the toilet through prompting and having cues around the environment, environmental cues and so forth. So we taught them a number of different processes. And what we found was when we brought people together in groups, and these were small groups, usually because we had people of all different cultures, we brought them together in cultural groups and language groups. And when we actually used group training and support, they did far better than those people had one-on-one. So some people had one-on-one coaching because they felt that they didn't want to share their stories with other people, and they were provided with one-on-one support at home. But those people that were willing to come together to groups did, and they seemed to do really well. So all over, everybody improved in their skills, they improved in their well-being and their health measures, and they improved in confidence, and they also improved in their willingness to get help, to seek help from formal services, whereas previously they didn't want to do that.
And Lynn, in a nutshell, why do you think the group experience was so effective? Is it something to do with shame and over normalisation of experience through peers? Well,
in some cultures, it was about shame, of not even wanting to identify that a family member had dementia, because if they had the view that dementia was about some sort of demon, or it was about having done something wrong in your past or being punished, we had to overcome those myths about dementia. So part of the whole program was educating people about what is dementia, what is going on. And when we identified what type of dementia their family member had, we were able to explain to them what was going on in the brain, showing them pictures of the brain and how it affected various aspects of the person's function. And so that was part of it, but part of it was also about wanting to keep it within the family and also not wanting to feel embarrassed. So overcoming those obstacles was the major thing. But when people actually did come together and they started to share their stories, and they could see that their stories were very similar in the effect that it had on the family and on the person, they were much more encouraged to support each other. So that's why group work is better.
It's so interesting because it's a kind of health literacy. What strikes me is I've done a lot of work in child protection, and there's been, as you would know, all of you would know, a lot of work on the incredibly powerful period of the first year of life, and even less in terms of the development of neural pathways, the development of the brain. And I've seen lots of education for sort of disadvantaged families or families with difficulty, showing them how important it is to stimulate the child and showing them pictures of the brain developing. And this is almost a health literacy issue at the other end of life, just explaining it's a physical thing that you can, it's not a shame thing.
Yes, that's right. And once they understood the damage that was occurring in the brain and what effect it might have and what it might have in the future as well, they were much more accepting of the situation. And instead of blaming the person and hiding them away in the bedroom and not letting them have social interaction, they actually started to enable the person to be part of the family and to be part of social life again. And that had a major benefit for the person with dementia. We assessed them as well, and we found they were very much improved in terms of their ability to maintain normal function when the families had been through this coaching program.
I need to go back to questions, but just one more from me. Grief. I just imagine that there must be terrible grief, whether it be a partner, a child, adult child, or whatever. How can people deal with the grief of the change in the person, where that change occurs and where it may in some cases be significant?
Well, part of the grief process that we actually talked about with people was actually letting them express how they felt, listening to their stories, providing empathy for their feelings, and then letting them just actually share things that they found helped. And one of the parts of this education program was to actually teach them to actually set goals for themselves very small goals to start with, and to monitor that whether or not the strategies they put in place are actually helping them to achieve their goals. And for some people, one of the goals was actually to start to come to terms with the whole thing and to accept the situation, but to see that there was a future, that there was hope, and that there were ways that we could actually help them through getting support, referring them to support, to help them find that support and to walk them hand by hand to access that support. That gave them the hope that things could be improved for them and for the person. And those little steps of achieving goals and seeing the goals were actually achievable and that they provided good outcomes helped them to develop even greater goals. So a goal, for example, might be to have 5 minutes on my own having a cup of tea without being bothered. Another goal might have been to be able to go once a week to go shopping and to actually invite someone to come into the home and to look after the person so I could actually go shopping. So some of those goals were achievable and they were achieved, and it gave people a sense of empowerment that their life could get back under control.
Look, thank you so much. And just a reminder, if you weren't with us earlier when Holly Miller from Dementia Australia gave a presentation, there is a national free dementia helpline that would be able to put you in touch with people in your part of Australia where you might be able to get access to the sort of support services and encouragement that Lynn's been talking about. Dr. Alan Schell, another question, please.
Well, this is one of the most common questions, that is, how do we manage the behaviours, the change in that person, and one of them is wandering, shadowing, screaming, angry, aggressive attitudes, and of course it's another fact that we will only have so many residential aged care facilities available to the public, and if you look at the numbers that are estimated out there, there are twice as many people with some form of dementia, so not everybody's going to get an aged care facility bed. And some of the work that I've done with Lynn and others with regard to patient-centred care, and that's part of what Lynn is talking about, how do you manage these behavioural changes? And I think it's a question for everybody, in that if we have wandering or there's a change in behaviour, how do we sort of start looking at that? And patient-centred care also goes to the fact that often, and we had that in Lynn training people, to improve the management of a person with unusual or behaviours of concern, without the use of medicines, knowing who that person was, and of course, teaching them what are some of those, not tricks, but obviously mechanisms or processes or pathways that one can undertake to reduce the behaviour of concern and create some normalcy around family, the carer, and for that person.
Look, thank you, Ellen. I'll come to Associate Professor Steve McFarland from Hammond Care, if I may. Steve, I guess my first question is, how common are the sort of behaviours that have been referred to, and what is the advice to people in terms of how to learn to manage those more challenging behaviours, as sometimes they're called?
Okay, the behaviours themselves are almost universal. You know, there's some studies that say the rates of behavioural change are as high as 95% in people living with dementia at some point during the course of the illness. The management, and I really want to make this point because it's vital, needs to be very much person-centred. Unfortunately, the mainstream... What does that mean?
It's almost a cliche now, so what does it mean?
Okay, well, take symptoms of agitation, for example. You know, agitation is a common disturbance in Alzheimer's disease. Now, agitation is not a diagnosis, it's a symptom. In much the same way, if we went to our general practitioner with a cough, and we'd be horrified if the GP sent us away with a cough suppressant, just a symptomatic treatment. We'd expect our local doctor to take a history of why we're coughing, whether it's a productive cough, whether we have a fever, whether they think it's bacterial or viral, maybe some antibiotics, maybe not. In other words, we'd expect an individualised treatment for our cough. Agitation in the setting of dementia is absolutely no different. And although certain drugs, certain psychotropic drugs are indicated for the treatment of agitation, that doesn't mean that they're the preferred treatment, because different people become agitated for different reasons. So a person-centred approach in the treatment of agitation would be taking the time to determine what in the environment is going on for that particular person at this point in time to make them agitated, and to gear our individualised person-centred treatment at that individual cause or causes, rather than simply trying to mask the symptom by sedating somebody with drugs. That's really what I mean by person-centred in this sense, Julie. And in many ways, that's a far more effective approach than drug-based treatments. I mean, the studies that have been done to get antipsychotics approved for the treatment of agitation and aggression in dementia, you know, firstly, you need to treat 5 or 6 patients to get a good response from one of them. Secondly, if you average the size of the effect, the magnitude of decrease in agitation and aggression that you can get from the prescription of these drugs, it's not much. It's 7 or 8% on average. And one of the great things I think we've been able to do with Dementia Support Australia as a national service that really takes this person-centred, individualised approach that de-emphasises the role of drugs is that we've got a database now of over 5,000 patients who've been through our program, where management has been person-centred, and our rates of reduction in symptoms like agitation and aggression are in the order of between 50 and 70%. So these things actually dwarf the effect size of drugs. The drugs can have serious side effects and at worst can result in premature death.
Steve, just before I ask you more about psychotropic medication, what was that national program you referred to? If someone's listening to this and they say, can I get in touch with what Steve's talking about and get help? What's the answer? What is it? And how do you connect?
Sure. So a partnership led by Hammond Care runs an organisation called Dementia Support Australia. And it's important to differentiate us from Dementia Australia. We are different organisations. So Dementia Support Australia specialises in helping both family carers and paid professional carers within residential care manage altered behaviour, primarily in a non-drug-based way. So DSA comprises 3 different programs. There's the National Dementia Behaviour Management Advisory Service that deals with lower level of behaviours, both in residential care and in people living at home. And there's the Severe Behaviour Response Team, which deals with the more severe behaviours. And we can get out and provide on-the-ground, face-to-face support, you know, within 2 to 5 days, depending on which program you're referred to. And that's regardless of whether a person's still living at home or in residential care. And we'd really like to encourage people to start using those holistic services, which actually don't harm people, are much more powerful than the drug-based interventions and are freely available through Commonwealth government funding.
Look, I'm going to ask you a question, and I'll also come to Henry about this in a moment too, if I could just alert Henry to that. I wanted to ask you about the Royal Commission into Aged Care Quality and Safety and what you see as some of, I know it's a huge process, but some of the key lessons and recommendations coming out of that so far, because there will be people watching this who have family members in residential aged care. So I want to ask you about that, but then I also want to come to the home, because I think it's a false dichotomy to assume that the home can't be a place of cruelty and neglect. Mm-hmm. You know, we don't all come from happy families. There can be difficulties in the home. But let's start with aged care services. What are your key messages about the use of psychotropic medication or other concerns, and what we as a community need to do to make it better for people?
Okay. I guess the key messages about psychotropics is that they're often ineffective. Where they are effective, they don't have a great effect size. They're not that effective. And in many cases, they simply cause harmful side effects. You know, the risk of being admitted to hospital with a drug side effect goes up by 20 or 30% within 3 months of starting an antipsychotic, for example. A lot of behaviours for which antipsychotics are prescribed, there's no reasonable basis to assume that they will do anything. You mentioned examples like wandering and urinating inappropriately and calling out earlier. I mean, I don't have an anti-wandering drug. There's no drug that has a mechanism of action that will stop somebody wandering unless you sedate them to the point where they're no longer able to do it. And that's true for many behaviours. So I think one of the key things that Council Assisting the Royal Commissioners has recommended is that there are restrictions put on who can initiate an antipsychotic. Most of the antipsychotics are prescribed in general practice, but not many are initiated by old age psychiatrists because there's not that many of us, as Henry has illustrated. I think that's a recommendation that has the potential to do significant good, but unless it's implemented properly, it might also do significant unintended harm.
Tell me what you mean.
Okay, well, if you restrict the prescribing of antipsychotics on the pharmaceutical benefit scheme, the PBS, the government subsidised drug scheme, if you like, that will stop general practitioners and others from prescribing a drug called risperidone, which is probably the most widely prescribed antipsychotic. It's quite expensive off the PBS. What it may actually do, if you stop GPs prescribing that, is make them switch instead to a non-PBS prescription of even older and worse antipsychotics in terms of side effect profile, like haloperidol or Serenase. So unless it's actually implemented in a way that covers all antipsychotics, there may be loopholes that simply shift prescribing to older, cheaper drugs, or indeed different classes of psychotropic drugs. I can see Henry raring to make a comment as there as well. Do you need to chip in, Henry?
No, keep going, Steve. You're doing well.
Okay, yeah. So there are unforeseen potential unintended consequences. As a corollary of that, and you're talking about other things that I hope will come out of the Royal Commission, and this was a recommendation from Counsel Assisting as well. It's to improve and increase the level of undergraduate training that doctors and nurses receive in relation to dementia. I'm always horrified when I see medical students who are in their fourth year, the year before they graduate as doctors. In their fourth year, they'll receive the first lecture they've had in 4 years of medical school on dementia, and they get a week to learn all that they need to know about age psychiatry. So dementia is not prioritised in the medical or the nursing undergraduate curriculum, with the result that if you ask most doctors and most GPs what they know about managing behavioural disturbances in dementia, it's pretty limited to what they can prescribe for it. So if residential aged care goes to the doctor for a solution, in a lot of cases, the doctor will do all he has been taught to do, which is prescribe. That may change if we can improve the training that all doctors get in their undergraduate training, and nurses as well. One of the big things in the Royal Commission has been pushing nurse ratios, for example, a set proportion of nurses to residents. And whilst that might be a great thing for aged care across the board, it's not necessarily the answer for dementia, because perhaps the one place where dementia is less well managed than in residential care is actually in our major public hospitals, which are full of doctors and nurses. But if they're not taught about dementia, they're not going to manage it well. The third plank, the third great white hope from the Royal Commission, is that there'll be better training in dementia for the basic level aged care workers who provide the ground level staff in residential aged care. Currently, the basic training that you get to be a personal care assistant, there's an optional module on dementia, which is very brief if you choose to do it. So making dementia part of the core curriculum for all aged care staff. And I guess in order to raise the educational bar for them, you might have to pay them significantly more as well, which might not be a bad thing, actually. So those are the three things that I'd prioritise: restrictions around psychotropic prescribing, improved training for both doctors and nurses at the level of their basic training, and improved training across the board for all levels of aged care staff. Julie.
Look, thank you. Henry Bedadi, can I come to you? And I'm looking for hope, if I may, and if I could turn to the home environment, because I know you're someone who does do home visits on occasion as part of your professional life. What are not just the challenges of what's happening at home, but the way forward to give people with a diagnosis the best possible life and their families?
Well, I mentioned before about living positively with dementia, finding and developing a routine, developing supports for the person to compensate for their deficits, working with the whole family, so that they work as a team, that just because, let's say, dad has dementia, we don't leave it all to mum to look after him, that we as the children or other relatives can chip in and help, and then work out a system and how to help. So there's lots that can be done. And Dementia Australia, what Holly told us about earlier, can provide support and guidance, or the coaching that Lynn talked about are some ways to do that. We've also done some training programs for family carers and shown that has a great benefit. It keeps people at home longer, out of nursing homes longer as well. So often family carers are the second patient. And that's a sort of maxim in this area of work, that we should always be looking after the carer as well, because in some cases, the person with dementia actually doesn't have a bad life. It's the carer who has the stress. You know, that woman looking after her husband might say, he has Alzheimer's, but I suffer with it. And she becomes isolated. She doesn't see her friends. She doesn't go for her morning walk or a coffee with her mates, or a game of tennis that she used to go, because her husband has become more and more dependent on her. So sometimes the carer can become so stressed that they lash out themselves in anger. And then we move into this area of elder abuse, which is something that we don't like talking about, but certainly does occur. And can occur in both ways, from the person with dementia to the carer, or from the carer to the dementia. But the answer is not to separate them. The answer is to support them. And properly supported, then people become less stressed in that way. But I think I've strayed from your question, Julie.
Well, I guess let me just ask one practical one, because I know that in about just over 10 minutes, we're going to move to a person in Melbourne who's going to offer information about sources of support. And I'm wondering if I should put the sources of support for those of us viewing in Sydney or New South Wales to you, Henry. Like, if someone's watching this, do you go to your GP? Do you go to the social worker at your hospital? Do you ring the Dementia Helpline? Do you ring the, where do we go if someone's just tuned in?
Okay, so yes, go to your GP, and some GPs are good and some GPs are not that good at doing this. You can certainly ring the Dementia Helpline that Holly told us about at the beginning, the 1-800-100-500 number. If there are behaviours which are very difficult to manage, then Steve's service, the Dementia Behaviour Management Advisory Service, under the umbrella of Dementia Support Australia. You can Google either of those and you'll come up with a number, or Steve will know it off by heart. You can go to your hospital for help. That's a long pathway. If you go through emergency department, that's many hours. If you ring up the old age psychiatry service, you'll need a referral, and then you'll be on a waiting list and you'll see somebody. So it's a complex maze, all the services for aged care, and navigating them is a real challenge. If you've got dementia, it's impossible. If you haven't got dementia, it's still very hard. And there are things like My Aged Care website as well, which are also very hard to navigate. There are aged care assessment teams who you can self-refer, or your GP can make a referral. And there's a waiting list, and then the ACAT will come and make the assessment and give you advice about what services you need, or put you on a waiting list to get a home care package. And the home care packages are 4 levels, from 1 to 4. There's a lot of publicity about the waiting list for the highest level of a year or 2 years. And sometimes people die before they get their package, or actually go into a nursing home before they get their package. So periodically we see in the media stories about this, and the Minister for Ageing becoming embarrassed and asking for more funds for this. So there are, with the complexity of ageing and the services, it is a hard system to navigate. Ideally, your GP should be the person to help you with that.
The only thing I'll add there, as someone who's walked this road as a daughter, is that if you have resources, and some of our viewers will, there are private services to support you at home, very expensive, but they exist and can be very helpful. And there's a growing industry and a quick comment from you on this, Henry, but I think that comes from the United States, this notion of navigators. whether you're in cancer care, there are cancer navigators. There are also navigators who are in private practice in the aged care sector. And if you can afford their fee, they can be enormously helpful to help you go through the maze.
Julie, this is music to me, music to my ears. You know, we were asked by the New South Wales the government to write a dementia services plan for New South Wales. This was 2009, 2012, and we wrote it, but then the government changed and that was the end of it. But one of the key recommendations we put in was for key workers or navigators. And this was introduced, not through our plan, but through the National Disability Insurance Scheme for younger people with dementia. It stopped now, but it was introduced for a few years. And it's obviously the way to go, because we have this system now where people have problems, a crisis occurs, they call for help. It's episodic, it's reactive. You had someone who's your guide who can navigate. It'd be continuous, it wouldn't be episodic, it wouldn't be reactive, it would be proactive, and you could avoid problems. And it's desperately what we need. There are dementia advisors in different areas of the state and around the country, but it's patchy and it's not always, people don't always know about them. But we do need a system like that.
Look, thank you. And I'm going to come to you in 1 second, Alan, for one last question. So something perhaps different. But first of all, if I could come to Lynn Chenoweth, our Professor of Nursing. For the carers watching this who are feeling a little bit bleak, because, you know, the more you learn about the system, while it's good to learn, it can be a little bit emotionally challenging. What's your message to them about getting help? What would you say? Where do you go?
Well, I think that, you know, it depends very much on whether you're already enrolled in some sort of service. But if you're not, I think that Henry's right. Go to your GP. If you're not happy with your GP's response, then I think you should seek another opinion. And I think that there are some specialist nurses out there who are very helpful, and they often work in community service roles. They often work through outreach from hospitals, and they're outreaching also from residential care. So I think that if you actually make contact with the services that are advertised and actually try to get some support either through your GP or through community nursing services, that can be your first stop. But if you find that that's not successful, you really do need to go to the dementia specialist services. And I think organisations like Hammond Care, Dementia Australia, Dementia Support Australia, those organisations, they know exactly who to put you in contact with, and they can quickly navigate through the system because I know it so well. And I think don't not go because it's difficult. Make sure that you actually find someone who can help you and walk you through this process.
And if I may, as a non-Jewish girl, say, because of course we will have many Jewish people viewing tonight, the Jewish community have some marvellous integrated services, communicating with each other, very strong volunteer base. So I just thought there is very much hope, I think, if you're in the Jewish community. I only come into these conversations so that should I need you, you'll let me in to your services. But Alan, one last question, please.
One comment before that, there's also the Holsworth Community Group, which looks after the greater eastern suburbs in this part of town, and there are like-minded community services that are out there that have NDIS, have home care packages that can be used, and they can help facilitate some of that home care.
And I think one of the last care as well. Jewish care is a
Jewish care, of course, yes, and we'll talk about Victoria Care shortly. The other one that is very common is they've heard that metformin, they've heard that Suvinay, they've heard that ginkgo biloba, they've heard that turmeric helps, and they're looking for that magic bullet. And Henry often refutes any of those because he's often asked to do some of the research on that, and I'm sure Steve is as well. So is there, except for the aducanumab, which is a very hard thing to say, we really don't have anything that's going to be modifying, unless the two other gentlemen here can highlight us to say, well, metformin is fine, but it helps you with your diabetes, but is it going to help your brain? And does turmeric really work, or is it just very tasty on your food?
Henry, can I come to you on that? What's our core message on what Alan's referred to, and also that enormous range of complementary medicines, alternative medicines that are in chemists these days?
there's no good evidence that they work. There's no evidence that they don't work, except for a couple of ones, like, oh gosh, I think I need to take some myself. But ginkgo biloba. So there have been 2 big trials of ginkgo biloba, which showed no effect. There is this Suvanade, which is this combination of vitamins and other ingredients. It's a nutraceutical, a medical food. The trial's just come out about 2 months ago or a month ago, showing that it may have some benefit, but the benefit is modest. But most of the array of medications you see when you go to the pharmacy on the counter there, you know, brain food and so forth, there's no evidence that they do any benefit. And so I don't recommend them.
Okay, and could I just ask Steve McFarlane, would you like to comment?
I think Henry's point is very good. There's no evidence that these things work, but it doesn't mean that there's evidence that they don't work. There are some laboratory studies that people like Professors Ashley Bush and Colin Masters have been doing for years around various combinations of antioxidants, preventing toxic free radicals or oxidation byproducts that damage cell membranes in Alzheimer's disease. If you were to take a cocktail of these antioxidants and add them to Alzheimer's disease affected brains, you can reduce the production of these free radicals. That's done in the test tube, but gee, you've got to be a believer to take a large cocktail of, albeit cheap, vitamin and mineral supplements for 40 years to possibly prevent a disease that you might not get if you live to the age of 90 anyway. I think the hope for these things, if indeed they do work, is probably in prevention rather than cure. I don't know of any treatment studies that have been successful. And probably the reason the research hasn't been done is that most of these compounds, like turmeric, they're dirt cheap and pennies a dose, and no drug company is going to make a buck out of it by doing a trial of 2,000 patients of turmeric, because they can't make money off the result. So there is some laboratory evidence that some of these things might do something, but the jury is out. There is no hard evidence. And, you know, like Henry, I don't routinely recommend these things myself.
Just before, thank you, before I hand back to Alan to, as it were, close down this primary section of our discussion, and we'll have a last intense look at support services in Melbourne. I just want each of you, because I notice we're not the youngest crowd on the panel tonight, with some exceptions, but I want one thing from each of you that you're going to do over the next year to give yourself the best chance of a healthy brain. And I want you to know, I have been treated for cancer, radiation to the head, and help me, what they squirt into your arms, guys, chemotherapy. And I have had an impact on my hearing from my chemotherapy. So having heard Henry tonight and on the health report, I'm off to get another hearing test to see how my baseline is going. I may need hearing aids. Henry, did you want to say something and tell us your tip, what you're doing? If you turn the mic on.
I wanted to say about hearing. The type of hearing loss that you get with the chemotherapy is probably sensorineural. It's damaging the nerves. The type of hearing loss that was associated with dementia wasn't that. It was to do with what was happening in the ears itself. So I think you're okay in that respect. Julie, I lead an exemplary life in trying to avoid dementia. I exercise every day. I eat a Mediterranean diet. I'm constantly busy cognitively. I try and socialize, but I'm not writing grants as I'm doing this week or the last few weeks. So I'm going to keep doing all of those things.
You're looking fab. What about you, Lynn? What are you doing over the next year?
Well, what I'm going to do is to wind down work, because I spent my entire life from the age of 14 working very hard, very long hours. And so what I'm going to do is to start living life and enjoying everything around me, enjoying my family, friends, and having a great time. And I think that'll keep me really well.
Look, I've heard social interaction is really important, so
Yes.
That sounds like a great plan.
Yes.
Steve, what about you? What are you up to?
Well, my cognitive New Year's resolution, and I do tend, unfortunately, to break this every year, Julie, is probably to try and drink a little less and exercise a bit more.
Okay.
I'll give it another go in 2021.
Yeah, well, we look forward to an update. I'll hand over to Alan now, if I may, who'll lead us into the next section. And I think we'll also thank and farewell our current panel. But over to you, Alan.
So mine is in the time that I've spent in research and working with Henry and others, I'm fitter and less fatter. I'm more cognitively aware. My memory's improved. I've got more time for my hobbies. And I think if people would like to just do something different in their next life, that's what they've got to do. There's the university of the third age. So, you know, take up art, take up improving my golf. All those things are very positive. And being here to educate people, I think, is very self-helping as well. So I'd like to say thank you to Lynn, to Steve, to Henry, to being here, and of course to our lovely Julie, and to everybody who's out there who's going to say goodbye shortly. That we will be having a whole new set of programs for next year, and Julie's been invited to do some of those Q&As with us again. We have a huge population of people who feel that Zoom is a good way to go, so we're going to keep up the momentum. So we know that most of you have had an email, so you can register. So if we don't have an email address, please go to the Wolper website, and we will have, if you email us and the Wolper website, we'll have the resources, Lynn's coaching, Henry, Rodati and others with regard to the Dementia Research Centre. And so all those resources will be available in the next week. And I can only say thank you very much. And we're going to now hand over to Mary Ann Hunt from Victoria to talk about some of the community services and some of the things that they do for Victorians. And all New South Wales and even up in Townsville, have a good night and stay well over the festive season. Have a good year, COVID-free one. So Mary Ann, over to you. Hello.
And I'll just introduce you a little bit, Mary Ann, if I may, and of course invite people to stay with us if they wish. But Mary Ann is a board chair with the Older Persons Network in Victoria and also with Elders' Rights Advocacy. So welcome to you, and tell our Victorians where they can get their support. Thank you.
Thanks, Julie. Well, it's really interesting. Well, congratulations, Victoria, being out of lockdown, which is wonderful to see.
Yes.
And it's certainly been a very difficult time for Victorians this year, particularly those older people who live in aged care facilities. So our previous speakers talked about navigating the aged care system, which is basically what I'm going to talk about today or this evening. And I've got a quick guide that I'll make sure that there's a link available so people can download. But I'll also be talking about giving some numbers that you can call tonight also if you want to touch base with anyone. I'm associated with advocacy groups, two advocacy groups. One's OPAN, the Older Persons Network, Advocacy Network, which is a national organisation. That national organisation supports 9 jurisdictional agencies across the nation in each state and territory. So the advocacy service in Victoria is Elder Rights Advocacy. And this is a service that is actually funded by the federal government and is a free and confidential service. This service provides education, information, and also one-to-one advocacy support to older people, their caregivers and representatives. It is independent, which means it's not tied to any service provider. It's about what is in the best interest of the older person and what they want to receive in relation to their care services as they age. Now, aged care, it's all about, aged care services is about living at home longer. We all want to live at home. I think for the last 30 years, and it certainly came out of the Royal Commission, that over the last 30 years, older people have told us they want to live at home. We keep on refusing to hear that because we haven't actually supported ensuring that the community services are there, but hopefully we'll see some significant changes in the near future. And the reason why aged care services exist is, one is to maintain good health and nutrition, keep your home in a safe condition, and stay connected with your community services and activities. And it's really important that we keep connected with our services within our community, and also our friends network as we age, because isolation, loneliness is one of the big indicators of someone's well-being as we age. Now, who's eligible for aged care services? Anyone who is 65, over 65, and if you're a Torres Strait or Aboriginal person, it's 50, over 50 years. Now, there is the Commonwealth Government set up a platform which previous speaker spoke about, which is the My Aged Care Gateway. And this is where all older people and carers need to register for services. Now, you can register for services when you need them, and you can also register prior to needing those services. And I would always encourage people to register earlier rather than later. On that note, I also would encourage everyone, when they believe there's some changes happening for them and they're finding maintaining their home or going out and doing their shopping or socialising or getting to doctor's appointments, get in some services to help you, because if we leave it too long, we tend to not want to have anybody in our home, because it's another anxiety issue that we don't know these people, we're not really sure, etc. So certainly I would always recommend earlier rather than later. And the other thing is that there's no one size fits all. We're all unique, and some of the previous speakers also talked about that we are unique individuals, and we need to be able to say what we need in order to remain as independent as we can living at home, or indeed if we need to access residential aged care. So first step is to register with My Aged Care. You can do that online. You can also ring the 1800 number, which is 1800 200 422, or you can ask your GP to make a referral. So there's three aspects of accessing the gateway. The fourth aspect is that you could actually ring Elder Rights Advocacy on 1800 700 600 and ask for an advocate to support you in doing that. So that's step one, register. The next step is to have an assessment, and the aged care, My Aged Care, will organise an assessment for you, and that is done by the aged care assessment team or one of the referral assessment groups, regional groups. They'll come out and ask you questions. It's usually done face-to-face, but obviously COVID has changed a little bit of that. And it could be done by Zoom or on the phone, etc. It depends on what's happening in your particular area at a particular time. Having said that, I believe all of Victoria should be able to receive face-to-face assessments as we speak. And those assessments, it's really about talking about your health and well-being and understanding where you're having challenges in your daily life activities. In that assessment, there are 3 levels of aged care services that you can access that are government funded. The first one is the Commonwealth Home Support Program, which is really a base level support program where you can actually receive services to help you with your cleaning, home maintenance, shopping, meals, social activities, transport to appointments, physiotherapy, occupational therapy, and personal alarms and more, and other things that you may need. The waiting list for this level 1 service is usually pretty short, and there is a limited group of providers, but there is also a limited amount of hours that you can access. But again, it's the level 1 of getting used to having someone come into your home and support you, because I don't know about you, but I'm actually always wanting to be very independent and in control of my life. So I think as I age also, I think I'm going to have those challenges that I think everybody is experiencing, having someone that they may need to depend on to help them maintain their independence. So that's the first level. The next level is the aged care package program. Now, this is the package care program that one of the earlier speakers spoke about, that is a long waiting list. And in fact, it's a fact that there are many older people who pass away prior to getting access to this service, which is appalling given the country we live in. And certainly this service needs to be funded more effectively and be more responsive to older people's needs. So it's actually about people who have gone from that really low level of care to moderate or medium to high care. There are 4 levels, and it's to be a flexible package. So it's actually about the individual themselves or their carer, the representative, saying what they want. And the funding is from 9,000 base package through to around 52,000 that you can be assessed on, and that's graduated from level 1 through to level 4, level 4 being the highest. These 2 packages, this program does have fees associated with them. One is an income test that's done by government, and then there's a basic care fee. The basic daily care fee that is charged is, in Victoria, from our perspective, elder rights advocacy, and what we know of what's happening out there in the community, very few providers in Victoria are charging this fee, and most will waive it if asked. So that's the basic daily care fee for the home care package. And then, of course, the next level is residential aged care. From my point of view, I think that if we can get access to the home care packages programs, a lot of people fundamentally can remain living in their own homes, even with dementia. I have actually, in a previous professional life, been the CEO of a community-based organisation, or several community-based organisations, where we supported many older people with dementia, and were able to live quite comfortably at home with supports.
I think the other thing is not only the money, is that how do you then help the carers? Because obviously that's, you know, yes, there's a cost, but I mean, as Lynn was talking about before, we need to be able to have people educated so they can become family as carers and make better utilisation of what's available. That's the big problem. Is there, you have a similar service of education available sort of that you're aware of? For carers other than Dementia Australia having some of their group meetings, do you have anything specific available?
We actually have the advocates, and we do education and information sessions to the community, and also within the residential care facilities themselves. And anybody could contact us, and we would be happy to. Okay. And I'm sure that any other of the other services within any of the other jurisdictions, particularly in New South Wales, which is Senior Rights Service, would be quite happy to come out and do an education session around accessing services. Okay. Other thing is the advocates through the network also can act on a person's behalf if they need to with the aged care, with My Aged Care. So that was something that we were able to negotiate about 18 months ago with My Aged Care, where the advocates can ring on the behalf of the older person and support them with the assessments, etc.
Yeah, I think that's often the issue. People aren't aware of these things. So we're going to, you'll leave us the information, and we'll then be able to distribute that to the people who've attended tonight. So I didn't have any specific questions that came up, but I thank you very much, Marianne. And to all the audiences still there, we still have, what looks like almost 100 people still listening. So that's great. So I think, thank you, Julie, again, and thank you everybody who's been, and as I said before, next year we'll be having a number of good topics, we hope, that will enlighten you and even entertain you. And we'll say good night. Have a good year. Hope it's COVID-free for everybody, and we're all going to have a holiday, at least in Australia. So good night all, and all the very best to you. Thank you. Thanks, Julie. Bye.
Thank you.
Bye, Henry.